So the first specimen is a Pura effusion specimen from a 68-year-old male. So it is a cytospin preparation. On low power, we can see there were some very large cluster along with some smaller three-dimensional cluster in the background. So when we go to higher power to see this cluster, it is very obvious that we can appreciate nuclear atypia. So the nucleus is actually in a triangle shape with prominent nucleoli, vesicular chromatin. So this looks like a adenocarcinoma with a three-dimensional glandular architecture. What is not common is in the cytoplasm, we can appreciate that there are plenty intracytoplasmic mucin. So because it is a Pura effusion specimen, this is very unusual if we consider the most common origin would be coming from the lung. This is very unusual for the lung cancer. So with this morphology, we will usually think about pancreatobiliary primary adenocarcinoma with mucinous differentiation. So these type of cells are very obvious in every cluster. So this is much larger cluster, and we can still appreciate very prominent mucinous differentiation of this metastatic adenocarcinoma. So the patient do have a past history of cholangial adenocarcinoma, which is a primary intrahepatic adenocarcinoma of the biliary tract. So this is consistent, the morphology is consistent with the history of cholangiocarcinoma. So we will send this out as positive adenocarcinoma and compatible with the history of cholangiocarcinoma. So we have a couple EUS guided pancreatic aspiration. So the first specimen, on low power, you can already appreciate the background seems to be quite dirty. We have a lot of necrotic debris. And when we go to higher power, these cluster of cells definitely show clear nuclear atypia with very hyperchromatic chromatin. But here we can still appreciate prominent nucleolus. This is overlapping with a very disorganized arrangement. So this is consistent with an adenocarcinoma. So we have a necrotic background. We have diagnostic cells of adenocarcinoma. So we can send these out as adenocarcinoma. Again, in this cluster, you can see the cells, the size of the cells is very big, and the nucleoli is also very big and it's prominent. So this is consistent with adenocarcinoma of the pancreas, high grade. This is the second specimen. So in this pancreatic aspiration, the cells are pretty scant, unlike the prior case. But if we go to higher power to see each of these clusters, we can still appreciate that definite atypical feature of a glandular cells with vesicular chromatin, irregular and prominent nucleoli arranged in this disorganized pattern, which means that the nucleus, the distance between each of the nucleus is uneven. Some is overlapping and some with a very big gap. And nuclear atypia is very prominent. So here we have another cluster. So on low power, even though it looks a little bit like honeycombing arrangement, but when you go to high power, you can still appreciate there are some like uneven distance between these nucleus. Additionally, you can also appreciate that if we draw a long axis of each of the nucleus, and these axial are all close with each other, so that's clearly this organization. So this type of arrangement we will refer to as Juncke honeycombing. So Juncke honeycombing is one of a typical presentation of adenocarcinoma of pancreas. Particularly, this could be one of the only clue that we can appreciate when it is a well-differentiated adenocarcinoma. So in this case, we have clearly Juncke honeycombing arrangement. So you can appreciate these two nucleus is very close, but these are distant apart. And additionally, each of the cell has very prominent nucleoli. So this is consistent with an adenocarcinoma. So this is another case of pancreatic adenocarcinoma. So the final case is also coming from the pancreas. This is a direct smear. So in this specimen, the liquid-based cytology is very overlapping, so not easy to see. But if we have a very nicely prepared direct smear, it's actually very easy for the diagnosis. So as you can see, in the background, we do not see a lot of like a normal cellular component, but here you can appreciate that in this cluster of cells, the variation between the size of the nucleus is exceeding of the, so what we call that 1 to 4 rule, that this is 4 times much bigger than the adjacent smaller nuclei, and within all one cluster, which is a clear sign of dysplasia. So this is consistent with an adenocarcinoma. So we have a lot of these clusters. So most of the cluster are cancer cells. Okay, so this is easy for the diagnosis. Here again, we have very overlapping, and here is very distant with each other. The cells show hyperchromasia, a little bit coarse chromatin, although the nucleoli was not very prominent, but because of this degree of disorganization, along with the chromatin change, this is still consistent with adenocarcinoma. So again, so here we have irregular arranged glandular pattern, much smaller nucleus, much bigger nucleus, all within the same cluster of cells. So this is consistent with adenocarcinoma of the pancreas. So the next specimen, we've seen this yesterday or the day before yesterday, that originally it says that it is coming from thyroid, but based on the cytomorphology, we know that this is most likely a parathyroid lesion. So we do cytospin preparation for immunocytochemistry. So this is the GATA3. GATA3 is a transcriptional factor, so it will express as a nuclear staining. So this is diffusely positive for GATA3 in the nucleus, so consistent with a parathyroid origin. Additionally, we also perform parathyroid hormone, which is a protein product. It's a secretory protein product, so it should be a cytoplasmic staining. So in each of these cells, you can appreciate in the cytoplasm we have like a clearly some dot-like distribution in the cytoplasm of almost every cells. So this suggests that these cells produce parathyroid hormone in the cytoplasm. So the stain is also positive. So we like an easy preparation. We only need to do the cytospin, and we can do a lot of different immunocytochemistry on this preparation with very good results. Okay, so the cells are positive for both GATA3 and parathyroid hormone, which is like a definite suggestion for parathyroid origin. So we will send these out. Although the clinician level thyroid will send these out as the other location, negative and compatible with parathyroid lesion and labeled as thyroid. Okay, so the next is also a finding the aspiration of a parotid gland lesion from a 72-year-old female. So this case is a little bit tricky. So on low power view, we do have hypercellularity, and you can appreciate majority of these cellular cluster, they were quite hyperchromatic and without a lot of cytoplasm, just on the low power feature. So when we see these type of cellular changes, we will consider as, could it be a basal cell or basaloid cells, or could it just be myoepithelial cells with a more prominent basaloid feature? Okay, so most of these cell cluster, we do appreciate they are like a tightly compact basaloid cells, but some of the area, this is a non-neoplastic acinar cell, so we can tell that we do have some normal parathyroid cellular component here. However, I think some of the cells, for example, here, it shows much prominent like a oval or spindle shapes. So the problem is that for these specimen, we do not find very prominent fibromyxoid, like a matrix, chondromyxoid matrix material. So some of the cells do have a more spindling pattern, which is more suggestive of a myoepithelial origin, and the other is a little bit difficult to determine. So our diagnostic consideration were between, could it be a salivary gland neoplasm with basaloid feature? For this type of diagnosis, we will usually use a SUMP category 4B, and the differential diagnosis includes basal cell adenoma, basal cell adenocarcinoma, or adenocytic carcinoma. But within this group of tumor, in our experience of cytohistocorrelation, around 35% of the cases will be malignant, which, like what I just said, includes either basal cell adenocarcinoma or adenocytic carcinoma. Around 65% of the cases were benign. Among them, around half of them were basal cell adenoma, but the other half were pleomorphic adenoma with prominent basaloid like a feature, or a cellular pleomorphic adenoma. So this is our differential diagnosis. Are we going to sign these out as 4A benign neoplasm or as 4B SUMP basaloid subtype? So this is the direct smear. Basically, the direct smear shows very similar feature. We have some of the cells look pretty basaloid, but it can also be suggestive of a myoepithelial cell. Particularly, we can see these dissociated cells and some with a little bit of plasmacytoid feature. Still, it's kind of difficult to appreciate extracellular matrix material over here. But I think this dissociative pattern is pretty good for myoepithelial component. So then we move to the Lewis-Stent, the final preparation. So in this Lewis-Stent preparation, although it is showing like a hydropic change, so the cell seems to be like a bubble up, but we can still appreciate these like a scattered chondromyxoid material, and has very close relationship with the cellular component. The most important thing is that this material looks very fibrillary. So it has a very indistinct border. So fibrillary type of matrix is one of the most important clue for polymorphic adenoma. So for the basal cell tumor, usually it will show much prominent chondromyxoid matrix with a more sharp like a border. So overall, I think this is most likely represent the polymorphic adenoma, but with predominant basaloid feature. So it's most likely a cellular polymorphic adenoma. This is coming from a 70-something-year-old female. So likely she would not want to have a surgery for this. So finally, I decide instead to call this SUMP. It's reasonable to call it SUMP basaloid subtype, but maybe we should just call this benign polymorphic adenoma. Okay, so we have these good features suggest it's likely to be a polymorphic adenoma. So we would sign the out as such. So thyroid. So this is direct smear because in the liquid-based cytology, it is very scant. So in this specimen, in the background, there seems to be no colloid, but we have this large chunk of material, and it looks like the cellular component was kept by some of these stromal components. So the cellular component consists of predominant oncocytic cells. So we have an oncocytic rich predominant aspiration. In the background, there is no colloid, and we also do not see a lot of lymphoplasmacytic component. So most likely, it is a oncocytic tumor. So this is a diagnostic of oncocytic tumor. So we will sign these out as TBS category 4, suspicious for follicular neoplasm oncocytic type. So finally, this is a pap smear coming from a 69-year-old female who had a past history of ovarian high-grade serous, primary peritoneal high-grade serous carcinoma, who has received debulking surgery 2 years ago. So basically, this is a smear for disease surveillance, disease monitoring. This is not a screening smear. So on low power field, we can appreciate it does not show a lot of normal component that we will see in the vagina smear. What is unusual is that it seems to be quite bloody. So this is one of the first clue that we need to pay attention that these might be a positive pap smear. Then we do see a lot of these very tight cluster showing glandular features, and with these hyperchromatic and irregular nucleus. And it's very three-dimensional, and the nuclear atypia is very obvious. So this is consistent with adenocarcinoma, and it's consistent with the patient's past history of high-grade serous carcinoma. So the patient is currently seems to be under a clinical trial or something like that. So this seems to be like recurrence of the disease, just based on these cytology smear. Okay, so we will sign these out as adenocarcinoma, and this is not a screening smear. This is a disease surveillance smear. So that's for all the case today. Thank you.